My name's Susan Heegard. I'm the president of the Midwestern Higher Education Compact, MEC. And most of you probably know that, but there are others invited who are not necessarily part of the compact. So just wanted to let everybody know that I'm going to just go through some housekeeping issues here, and I'm sure I'll forget something. If you have a question, there'll be a chat function rather than raise hands because we have so many participants. Please post your question in the chat box and we'll call on you. We will be taking questions during the presentation and after, so it's really up to you. When the spirit moves you, please ask your question. We've got about an hour for the presentation. The recording, we're recording today. So if you would like to tap that later or share it with others, that will be available to you. The slides will be shared and available to you as well as some resources that Dr. Gould will likely be sharing with us. We have live captioning. We're piloting and experimenting with this because we're actually going to be using it for our annual meeting on November 9th and 10th. So there will be live captioning, and that link is in the Zoom in the chat function, correct? Let's see. Make sure you use your mute button. I will try to remember that as well because all sorts of noise can be picked up in the background. And then just from experience I've had recently, if you're going to put your laptop down, turn your camera off because you never know what that laptop will pick up. Some unintended consequences there. So with that, Mary and Katie, am I forgetting anything?
You're good.
Great. I have the great pleasure of introducing Dr. Deborah Friesen, and Dr. Friesen will be introducing our special guest today. Dr. Friesen is one of our MEC commissioners from the great state of Nebraska, and she's just not that busy. I wish she were busier, Deborah. She is the Deputy Commissioner for School Improvement and Support for the Nebraska Department of K-12 Education. And she is also the chair of the Nebraska Coordinating Commission for Post-Secondary Education. We're pleased to have you, Dr. Friesen, as one of our MEC commissioners and look forward to your introduction and Dr. Gould's presentation today.
Good morning, and thank you, Susan. Again, my name is Deb Friesen. I'm MEC Commissioner from Nebraska, and I have the pleasure of introducing to some and reintroducing to others Dr. Jeffrey P. Gould. In early 2014, Dr. Gould was appointed the 8th Chancellor of the University of Nebraska Medical Center, Vice President of the University of Nebraska System, and Chair of the Board of UNMC's Principal Clinical Care Academic Health System Partner, Nebraska Medicine. As UNMC's Chief Executive Officer, Dr. Gould is responsible for all aspects of campus leadership, program quality and operations, including 7 colleges, numerous institutes, a staff and faculty of about 5,000, and its 3,800 students. Additionally, Nebraska Medicine has over 6,500 employees and an operating budget of well more than $1.5 billion. The combined economic impact of the 500-mile campus academic health center exceeds $4 billion. In April 2017, Dr. Gould also was named Chancellor of the University of Nebraska at Omaha, our state's public metropolitan university. The University of Nebraska at Omaha has an enrollment of over 12,000 undergraduate students, 3,000 graduate students, a broad public service mission, and an NCAA Division I athletic program. It was announced last week that on July 1st, 2021, Dr. Gould will step aside from UNO and will add the system-wide role of Executive Vice President and Provost to his title, pending Board of Regents approval. Dr. Gould will remain Chancellor of the University of Nebraska Medical Center, and his new role opens an opportunity for the university to fulfill its plan to have separate chancellors for UNO and UNMC. University of Nebraska System President Ted Carter describes Chancellor Gould as the right person at the right time for the job. That leading both of our Omaha campuses has been an incredible undertaking. Thanks to Chancellor Gould's leadership, along with the work of UNO's talented faculty, staff, and students, UNO is on a remarkable upward trajectory. We're expanding access to our increasingly diverse student body, The research enterprise is growing in scale and stature, and the campus is a national model for engagement and service to its community. And under Dr. Gould's leadership before this time, and especially in these times, the University of Nebraska Medical Center has become known as a world leader in fighting infectious diseases. In response to the COVID crisis, UNMC's expertise has been sought nationally and internationally, and they have been uniquely positioned to respond. They have provided groundbreaking research for a vaccine. Additionally, Dr. Gould and his team of medical experts and academics have provided an extensive checklist to serve as a playbook for the reopening of American higher education. And they have created and made available a contract tracing phone app and Tableau data tool. In June, Dr. Gould presented to MEC's executive committee, and he shared his experience leading an academic institution and in leading a medical center that has been central to the national and international response to the global pandemic. His presentation then, Opportunity and Innovation in a Time of Uncertainty, How the University of Nebraska is Responding to the Global Pandemic. Please help me welcome back Dr. Gould as he provides an update to his presentation with a current perspective on this fall's return to campus and his views on what to expect in spring 2021. Thank you, Dr. Gould, and welcome.
Well, thank you for your very kind introduction. It's an exciting time for the university system here, for me personally. Although I will tell you, I get asked all the time, what's my favorite title? Chancellor, fill in the blank. My favorite title is actually Grandpa, and I'm going to stick to that. And fortunately, I have two wonderful grandchildren, and I wish I could see them more often because of all of the virus-related things. So what I'd like to do is just share some updates with you and then really use as much of the time as possible for answering your questions. I have put together a PowerPoint deck. I do want to demonstrate one of the data collection tools that we use for making local decisions here in Nebraska, and then use it as a time to answer your questions. Also, anything that I say, I'm more than willing to share. And I'm a nearly recovered pediatric heart surgeon by background, spent most of my life on the East Coast clinically. And so I don't pretend to be a public health expert, but I get to work with them. And so I've learned a lot from listening and reading and other things. So let's start off with a bit of a screen share. And so let's see if this is going to work. So are you seeing this screen? I hope you are.
Yep, looks
so
good.
I've chosen actually not to change the title because I still think it's opportunity and innovation at a time of uncertainty. We just know a bit more about it. And at the time that I spoke with you several months ago, I introduced the Global Center for Health Security, which has been around for going to be 20 years next year, going back to the SARS time and the immediate post 9/11. Our partnerships are broad, and just not knowing how many people were on the call then, just want to make the point that we are very, very deeply partnered with Health and Human Services, and particularly with ASPR, Defense, Strategic Command, Department of State, and of course, Homeland Security. I actually spent 3 days in Washington earlier this week. It's actually the first time I've been back in several months, and I can tell you, you would never know Washington as it was in terms of how empty it was and all the changes that have occurred, but no shortage of work. Global Center of Health Security is involved with chemical, biological, radiologic, nuclear, environmental, etc. Threats and challenges, which we currently deal with on a day-to-day basis, but also a series of newly emerging, re-emerging, and what are known as deliberately emerging diseases. You don't see a lot of deliberately emerging diseases on this map, just because I could tell you about them, but they'd have to kill you. So we'll leave that for another time. But obviously today we're going to talk about COVID. And just to make the point that there is an extremely delicate balance, which we are well aware in our world of education, between the social and economic aspects of this, and of course the health and wellness aspects of this. And this balance is extremely delicate, and it's all things K-12, it's all things employment, it's all things social isolation, it's all things pandemic fatigue, early childhood, and of course higher ed is in this balance as well. But in order to understand the comments that I'm going to make, we have to be realistic and look at the data. We broke the 9 million confirmed cases number yesterday in the United States and reported for the first time in history over 90,000 confirmed new cases yesterday. That's 42% higher than it was 14 days ago, which is one disease transmission cycle. In addition to that, what we were seeing previously as bi-coastal spread of the disease in the very dense urban centers is no longer the case. And we are seeing the country is actually now led by North Dakota, South Dakota, and Wisconsin, followed by Montana, Wyoming, and Alaska, and then followed by my home state, Nebraska, Idaho, and then Utah. This is the top 10, or in this case, the top 9. And you see here not only the US hotspots, but you see here the college and universities across the United States that are currently reporting cases, which are well over 240,000. And by the way, we've now confirmed 70 deaths in that setting. So this is not just about asymptomatic or minimally symptomatic spread, but is clearly and tragically about hospitalization and death. We continue to report approximately 1,000 deaths per day. And by the way, the current estimates last spring were that the test numbers were off by a factor of approximately 15. That is to say, for every case reported, there were probably 15 others that were not reported. With the widespread use of testing right now, that number is somewhere between 3 and 5. So conservatively, if we reported 90,000 cases yesterday, we're probably just under 300,000 cases reported that existed in one day in the United States. And we'll talk a little bit about the consequences of that, but going back to April, this is what the hotspots in the United States looked like in cases per 1,000. This is what July looked like on the same type of map. And this is what it looked like a couple, 2 weeks ago. And unfortunately and tragically, it doesn't look any better today. I would point out to you that not only is there a considerable shift away from the coasts, but there's a very dense and very critically important shift to the rural farming and ranching communities of our state, as well as to the small and moderate-sized cities in the Great Plains, the Midwest, etc. So as I told you last time, that while a lot of our work, and this is just an example of one of our mitigation and response guides for higher education, it's the only one that I considered even being a co-author on, and it was against my better judgment, but I was talked into it. But that any and every decision that has to be made in higher education has to be made in the context of what's going on with transmission in the local communities and what's going on with clinical resources. And so to paint a picture of that for you, these are the key community mitigation decisions that are actively being made. These are very constant of scientifically based decisions, testing, tracing, and more testing, constant genetic antibody and viability testing, which is critically important, and real-time data-driven decisions on not only transmission rates, but healthcare capacity, and that means workforce and supply chain. It's useless to have hospital beds and ICU beds and ventilators if we don't have workforce and if we don't have supplies. We still firmly believe in regionally determined real-time decisions with multi-stage transitions and then decisions which will become very important in the near future regarding vaccines and antivirals, particularly in K-12 and in higher education. So I thought I would actually give you an example of some of the recent data that we're looking at. And our attention has been focused very highly on Wisconsin right now. And unfortunately, 221,000 confirmed cases, October 28th, 4,000 more cases, up nearly 40% in a 14-day period, and just under 2,000 deaths, which has doubled, hear me say doubled, in a 14-day period. This is interesting, the list of the counties with the number of confirmed cases in the United States. And as you see, Brown County, Wisconsin is at the very top, followed by Lubbock County, Texas, El Paso, Winnebago, Illinois, Utah County, Utah, etc. So the data that I really want you to look at is some of this age-related data. And I think this is particularly important. This is Wisconsin data broken down by age. So in the light blue, you're looking at less than the 18 years of age. And this goes back to April 12th of this year. In the green, you're looking at the 18 to 24 age group, which of course we're particularly interested in. I think one would not have to argue very much to agree that Wisconsin is on fire. I think and in small and large communities. And the older age groups, of course, greater than 65 here are in yellow, 55 to 64. So the point I'm trying to make is you go back to the third week of August, and this is when the colleges reconvened in the state of Wisconsin. And you look at what has happened in green here, which is the 18 to 24 year age group. There's very little question in the timing of what's going on in the rest of the state as to the connections between these families of curves, regrettably. If you look at here, this is the diagnosis in the state of Wisconsin, going back to the very beginning of the pandemic. At this point in time, bars reopened. And I would argue with you that while it may have produced some libation on the weekends and late afternoons, it didn't have a lot of effect on the cumulative impact on the number of cases. But look at the impact here of when the colleges opened in the state. I would point out to you that the 10 to 19 age group are here in the blue, and the 20 to 29 age group are here in, let's call that turquoise. I think it's inescapable to point out the relationship between this arrow and this timing, not to say there aren't other things going on, the weather's changing, I mean, there's endless numbers of other things that are going on. But I just think that these data are important to share with you, as each of you will have to make decisions. We come back to the pandemic mitigation guide, and the point is that the single best thing we can do is eliminate the virus, which means talk about vaccines and antivirals, substitute the virus. Right now, there's nothing to substitute it with. Engineering controls, which have to do with air handling, densification, and things of that nature. Administrative controls, and then finally at the bottom of the pyramid is PPE, because it's the hardest to enforce. The supply chains are the most delicate, and of course it's the most politically charged and some of the most controversial decisions that we collectively have to make. I'm going to show you some of the PRAM data in a minute, but this is the way that we look at it across the state of Nebraska, and it's been made available to multiple other municipalities as well. But the pandemic recovery acceleration model really tries to give us some real-time look at both case transmission rates as well as hospital and supply chain utilization to help us make density decisions, open and closure decisions as well. We have, as I told you earlier, planning to use a series of smartphone apps that are known as the OneCheck Covid family. Each of our campuses has its own app, which is with its own database that looks at students, faculty, and staff across the entire campus. It's available on Apple and Android as well as web-based platforms, and it's widely used. Over 100,000 users. Think of it like a passport. You get a green check. You can enter any part of the campus, be it our residential facilities or our libraries, our classrooms, etc. If you don't have a green check, you at least need to talk to our campus health security folks. This is the chart from 6 a.m. this morning. So just as of this, very small number of the students had actually already logged on, 342, 10% of those that we're currently tracking. But you see we had 6% in the red, about 8% in the yellow. The majority are low risk. This produces an immediate call, and this is all based on self-screening, contact exposure, and testing. We have a separate subset that looks only at the residential facilities as of 6 a.m. this morning, or a little earlier than that. You might ask, what am I doing online at 6 a.m. this morning? That's subject to a whole separate discussion, which we can have over a glass of wine sometime. But this is what's going on in our res halls as of today, which is provided to all of our resident advisors, et cetera, to continue to monitor exposure. There is no question that our campuses are the safest place to be if you're a student, faculty, or staff. The spread in the community is much greater. So again, I come back to the key professional and pharmaceutical interventions, which include, from our perspective, test deployment and development. Antibody testing is very important for measuring immunity. Syndromic surveillance, whether it's done through the smartphone app or some others, I leave that to your decision, but knowing what's going on in the community is key. Routine campus-based contact tracing and identification. We have 100% on-campus use of that. Obviously, reliable and timely data collection. We publish campus data, spread, contact tracing information, et cetera, every single 24 hours, including the dashboards that I just showed you. Obviously, we are working very much on antiviral and vaccine development here, working very closely with our federal partners, and we can talk about that if you're interested in it. Mitigation and response guides. We use our checklists constantly for thinking and rethinking what we're doing, and then trying very hard to stay aligned with federal, state, and community actions, which some days are easier than others, and we can talk about that as well. So before I show you today's dashboards, just again to remind you, I would be remiss if I didn't share this with you. The key community mitigation actions are certainly, if you're ill, stay home and self-isolate, notify the public health folks. Someone in your household is ill, pretty much the same. Participate in all reporting and contact tracing programs. Statewide now, we are at about a 25% level of confirmed cases refusing to participate in contact tracing, which does not portend terribly well. Reduce student density in school, childcare, and certainly limit group events. The overwhelming amount of spread that we are seeing does not occur on our campuses. As a matter of fact, based on our campus contact tracing, 85 to 88% of the spread in the entire University of Nebraska system is actually occurring in the community and not on our campuses, which is why I said they are some of the safest places to be. Face coverings and masks inside and outside the home. Wear a mask, wear a mask, wear a mask. Appropriate utilization of medical facilities, workforce, and supplies. Obviously, we don't want to underuse them, but we don't want to overuse them either. It's really important. We are seeing a ton of underuse of people that are having heart attacks, serious mental health issues, just ongoing challenges, delayed mammography, which is resulting in cancer diagnoses. So we need to keep that relatively well balanced. Self-screening with public health surveillance programs. And then again, very important to stay, for all of us, particularly our young children, to stay current with all available vaccination schedules. And that, of course, will definitely include flu vaccines. We don't want to get into a situation where we are seeing flu transmission, delayed flu vaccination, and availability of vaccines for COVID. So please do get your flu shots. I did. We usually find a very caring undergraduate student in one of our programs, typically a nursing or a pre-pharmacy student, to provide me with my vaccine on video. It's always an interesting experience. This year, I might point out, was particularly painless, or maybe I've just become numb, who knows. Everything that I've just told you is available on the unmc.edu health security website, and I'm certainly willing to make this deck available to you. So before I answer your questions, I thought I would just very briefly show you today's dashboard, which might be of some interest to you, which is how we do track this. It's run in a format which is called Tableau. And why can't I share this? Let's see. Here we are. So this is updated every 24 hours. This is the October 31st, 2020 version, which means it's going to be pushed out at 6 a.m. tomorrow morning. It is data through midnight last night. You might ask, why isn't it pushed out today? And the answer is we do a good deal of data validation. But so this is called the welcome filter page. And this is the 93 counties, 6 healthcare coalitions, and 19 local public health districts in the state of Nebraska. So for instance, I am speaking to you from what is known as the Omaha Metro Healthcare Coalition, and that would be these just 6 counties here. We can slice and dice the data any way you want to look at it. So for instance, if you were interested in Dawson County or Buffalo County, where the University of Nebraska at Kearney is, you could look at one county, you could look at their local public health district, you could look at their whole healthcare collaborative, which is known as Twin Rivers. So here's the state of Nebraska as we speak, as of midnight last night, 627.93 cases per million per day, 24.29% test positivity, and 0.34 deaths per million per day. We're at 249 hospitalizations with COVID per million in the state, which would be a total of 482 patients. These are 3-day rolling averages, by the way, to blunt out the impact of the weekend case reporting. 68 ICU beds and 22 ventilators. These are the velocity changes. So for instance, statewide, the number is 1.03, which means we're at about 103% of where we were 14 days ago. And given the fact that we're on fire across the state, not a terribly good place to be. So this would be the disease rate of change, also known as the R0, and this would be the resource rate of change. And so the point being here is that we are burning through healthcare facilities at 134%, nearly 135% over this 14-day period. So we're burning through resources faster than we're accumulating cases, which is frankly not where we want to be. If you were to look across the state at the 6 healthcare collaboratives, you would see where we are in any of those 6 regions. These are the disease dials. You see they are quite different, whether you're in the Panhandle, the Omaha Metro, Lincoln, Lancaster, etc. But we also produce this on a graphic way as well. So this would be the whole state. This goes back to the beginning of the pandemic. This is the number of cases per million per day. We thought we peaked out here on May 9th at 240 cases per million per day, and 627 2 days ago per million per day. This is test positivity. So even though the number of tests has continued to gone up in the state by the tens of thousands per day, we are currently, ticking along at nearly a 25% test positivity. This looks at deaths per million per day. Here you're looking at hospitalization per million per day. So we had actually thought that our hospitalization had peaked out on the first week of June at 113 hospital beds per million population. We're actually nearly at 250. This is ICU beds statewide. And as you see, we're at 68, and this is ventilators statewide. By the way, that's about what, 40, 50? But the beauty of this is that you can get down to very local districts. So for instance, if we wanted to look at Douglas County, which is where University of Nebraska at Omaha is and at where the Med Center is, you can look at these trends and make your own decisions for each of these metrics. Or for instance, if we wanted to look at Lincoln Lancaster, we could easily do that as well. Let's see, where's Lincoln Lancaster? Right here. And the interesting thing about it is these patterns of hospital utilization, case transmission rates, et cetera, are quite different depending on how granular you actually slice and dice the data. The last thing I wanted to show you is let's see, some of these charts here. And these are, again, going back to the very beginning of the pandemic. And these are the summation velocity charts, meaning the R naughts. So I just particularly want to call your attention to this one in the lower right. This looks at the rate of disease progression compared to the rate of resource utilization. And the point being is here, when you're in the green, the disease is progressing faster than we're burning through healthcare resources. When we're in the yellow and red, we're burning through healthcare resources faster than the disease is progressing. There is no question that there is this sinusoidal curve that recurs at about a 3 to 4 week interval. We are now deeply in the green. We're at a factor of about 0.638 on October 20th. There is no question that the sinusoidal lift is going to occur here. Now, this is statewide, but if you wanted to go out to some of the smaller local public health districts, and for instance, the Kearney campus is out in what's called the Loop Basin Local Public Health District. So if the UNK people are trying to make decisions regarding events or other considerations, they could just look at their curves and they could make some decisions regarding future planning as well. So I hope that's helpful information to you. We're more than willing to share any of this or none of it or whatever would be helpful. And with that, I'm just really pleased to take any questions that you may have.
Jeff?
Thank you, Dr. Gould. I'm going to ask you, I see Randy here, but Randy, can you, I think the best thing, if you can type it in the chat function, great. If you can't, then we could just take your question. Now, I want to do a time check with Katie and Mary. Do we have until 11:30 Central Time?
That's correct, yes.
Great, thanks. Randy, looks like you want to ask a question.
Yeah, I have twofold. Which tests do you recommend? Because there's a variety of tests that we're all subjected to. I've had the PMR one, the most refined, but you know, places like Costco have testing sites, and the university recommends different. And then how valid are, like, the antibody test? I understand that a lot of false positives in there. And so I'd like you to discuss a little bit of that. And the second thing is that what are your recommendations for people, just ordinary things like take aspirin, have vitamin D, take your flu shot, and those type of potential.
In answer to your second question, Dr. Furlick, is yes, yes, and yes. Take aspirin, get your flu shot. I do believe in vitamins. I take them myself. But you know, I'm wearing my N95s out too. When I go grocery shopping, go to the pharmacy, meet other people, there's nothing that you can do that is lower risk and higher yield than wearing a mask. Nothing. I don't, you know, there are a lot of other things we can do, you know, physical distancing. I hate the word social distancing because we want to be socially connected, but physically distanced. Sanitizers, hand maintenance, you know, all of that kind of stuff, group gatherings. I mean, there was a wedding here in Omaha with 500 people 2 weekends ago. I mean, we know what that is going to cause. There is no question about it, other than marital bliss. I'm sure it's going to cause that, but a few other things might get in the way as well. But coming back to your very important question about testing. So we do a lot of the validation work with the FDA. We do all of the validation work for the state. And so the standard test, the PCR test, is the genetic test that measures the presence of fragments of genetic material from the SARS-CoV-2 virus, which is the etiologic agent of COVID-19. It is the highest reliability, the highest sensitivity, and the highest specificity. In a well-run, high-throughput laboratory, it is over 95% sensitive and 95% specific. Once you get away from that, you start to get into very different results. So we have done a lot of work with the antigen tests, which are so-called point-of-care testing. These are the nasal swab tests. And so we have looked at random sampling through hundreds of different long-term care sites and others across the state. And the sensitivity and the specificity are quite different. The specificity is high. It's probably over 90, independent of which test you look at. The test we've had most experience is with the Abbott test, but we've actually looked at 4 of the different tests, but that's the one that's most widely available now. The issue really relates to the sensitivity. And we have determined that in the best of hands with the best specimen collection and the best processing, it's between 60 and 65% sensitive. That means you're losing between 40 and 35% of those that are actually positive on PCR. In less than ideal hands of sampling and less than ideal hands of processing, it is 16 that would be 16% sensitive, meaning that you're missing 84% of the people that are tested positive on PCR. Now, the 60% to 65% sensitivity may not be all bad because there's a very serious question as to whether the PCR testing is overly accurate. So the way we use it is we use it as repetitive screening. So we use the antibody tests, the antigen tests rather, for high volume, repetitive. So think student athletes, think long-term care, think random screening of students and things of that nature. That's where it really becomes important. But certainly anybody that's read on the app, anybody that is symptomatic, and anybody that tests positive on an antigen test needs to be PCR tested for purposes of confirmation. The other thing I want to point out to you is there are a number of antibody tests that are available. It's less clear what positive antibodies really mean unless you know that you're being tested with a test that uses what are called type S specific, which is spike protein specific neutralizing IgG antibodies. Short of that, a lot of these tests have tons of false negatives and false positives. Long-winded answer, but I think it's really important that we understand what we're reporting.
Thank you, Dr. Gould, and thank you, Dr. Furlick, two Nebraska heart surgeons. So I'm going to walk through, pardon?
Recovering.
Recovering, yes. You're both recovering well, it looks like. So I'm going to run through these questions. I have a couple of my own too, but I think out of fairness, I'll ask the questions here in the chat box. So Chancellor Hagerott in North Dakota is asking you, based on your data analysis, Dr. Gould, do you believe and expect your colleges to remain on campus through December, or do you believe they should go remote online very soon?
So I'm going to try to answer these questions in a very brisk and staccato way. Yep. Each of our campuses has done what we can to de-densify up to the Thanksgiving holidays. Each has a somewhat different program, but we've worked very hard to try to minimize return to campus and go to a more virtual, de-densified environment for any academic programs and, of course, finals after the Thanksgiving holidays. We are planning a full J-term, January term on our campuses, and we're also planning a full spring semester at this time. But again, a lot of it's going to depend on the testing. The current predictive models, I won't go through all the details for you, but the best way to state it, it's going to get significantly worse before it's going to get better. So we think we need to maintain maximum flexibility as we get into the next 2 months.
Great, thank you. All right, we've got another question here. I'm going to piggyback my own question. I hope the questionnaire doesn't mind. What the question here is, could you share the cost of the cell phone app you're using? And then I'm going to ask a second part, which is, could you then, after you respond to that, comment on the PRAM index or the tool that you're using and how you've said that, I think to me that about 7 other states are using it. How might another state use this and how could they adapt it? So let's go to that cell phone question first and then talk about your other tool that you have highlighted here today.
Okay, so the Global Center for Health Security here at UNMC built the apps that are customized for various businesses, college campuses, et cetera. To us, it's, how do they say in the MasterCard commercial, it's priceless. But actually the original design was done with 3 undergraduate students in our tech department, in our tech programs, and 75 Apple engineers. So if any of you are interested in access to it, if you let me know, we can easily help provide it to you. I don't know what the cost of customization would be, but it's very de minimis as long as you are willing to support it and use it. You will see that there is a lot of static early on in, who's getting what kind of data. But at the end of the day, if we want to keep classes open, maintain college sports, go to church, we're going to have to be able to willing to do this.
So I'm sorry, for the cell phone app, there is a cost and
Only
what's
if
the
there
best
was
way for
some
them?
customization that, in other words, if you
Yeah.
want your logo on it and you don't want our logo on it, there probably would be a cost. Otherwise, it's a gift.
And what's the best way for them to
Just
get in
contact me
touch?
directly.
Really? All right. Awesome. Great. Okay.
And as
then
far as
second
the
part-
PRAM tool is concerned, I would say exactly the same thing. If you would like to have access to it, frankly, if it's just the code you want, it's a gift. If you want it customized for your community or for your state or whatever, I mean, we have talked, every state in the country is aware of the use of it. There are several that use it more commonly than others. They typically are, they're on both coasts, would be the best way to put it. There's no other Midwestern state right now that's actively using it that I'm aware of. They look at our data all the time because I know that I'm feeding it out to the public health directors of all the surrounding states around us. But we're actually about to come out next week with a new version that's much simpler and easier to use. So if any of you have an interest in it, this would be a good time.
Great. All right. Thank you. The next question here comes from Senator Nespa in South Dakota. He wanted you to comment on the recent trends in South and North Dakota and what you might recommend to the universities there. As you know, those are states with populations not too dissimilar from like a Wyoming or Nebraska. And so a few concentrated, metro areas, but largely rural.
I think it's the same non-pharmacologic interventions. The key question that I get asked all the time is what is the threshold going to be to start to close down campuses and go to completely remote education? And I don't think there's a single answer to that question. For instance, if we ran out of hospital beds and ICU beds, that would be one of the things I could not in conscience keep our students on campus and our faculty and staff, because we are extremely de-densified. I would say we're at about 25% of usual density on campus right now, 75% remote. And that's been pretty stable through the fall semester. We've had we've had just about 200 total cases at UNO out of a total population of about 16,000 students and roughly, 3,500 faculty and staff. So, it's really very small numbers. At the Med Center campus, we have had under 50 confirmed cases, students, faculty, and staff, since the beginning of the fall semester. So that's the other factor that we look at very carefully every day, which is very simply the question of what's campus transmission like? What are we seeing in our res halls? Are we losing students in classrooms? The answer to the question thus far, it could change tomorrow, but thus far we are not. So we are not further de-densifying the classrooms.
That's great. Thank you. All right, next question's from Dennis Olson. Dennis is the Commissioner of Higher Education in Minnesota, and he asks, here in Minnesota, we had a small private college make the decision to close and transition to full online delivery earlier this week. They unfortunately recommended students go home following the closure announcement. Our office and our Department of Health obviously don't recommend this. As we enter this period of increased concern, how have you in Nebraska messaged the importance of staying on campus?
Well, we have been in a position from the very beginning of this of saying that the safety and health of our faculty, students, and staff is the North Star of every decision that we make, and that we will do everything we can to maintain campus safety. As I said earlier, right now our campuses are one of the safest places to be because of absolute mandates with masks, smartphone apps, social distancing, tons of, limitless amounts of hand sanitizer. I think we live in that stuff these days. So we work very closely with our local public health districts, and we, are doing everything we can to maintain campus safety. I think the message has to be regional. I don't think it necessarily can be or should be statewide, and which is why each of our regional campuses gets their own data set and looks at their own data set of what's going on in the community and what's going on their campus. I don't have a single threshold, Susan, as to what the trip point is to make a closure decision.
Mhm.
There are all kinds of legal risks that go into it, as well as practical matters, financial matters, of course, as well. But again, the driving factors for us are health and safety.
Great, thank you.
The way I articulate it is pretty simple. I remember the days all too well. I have two wonderful children, and I remember what their college days were like. I would not make any decision for our students that I wouldn't make for my kids. It's just that simple.
Excellent, thank you. From our chair, Olivia Madison, she asks, what do you assume the impact of both COVID and the flu generally have on campuses with winter upon us?
A lot depends upon flu vaccine utilization. However, if you look at the South American data from their previous flu season, flu numbers were extremely low in those communities that wore masks and got flu vaccines. Their hospitalization rates and their death rates were probably lower than they've been in 20 years. Those communities that did not have a lot of adoption of flu vaccine, masks, and other such things had terrible flu seasons that just sat on top of COVID. So it's in our hands, folks.
I got my flu shot.
Or maybe in your arm.
shot.
Yeah, there you go, Susan.
All right, from Helen Van Etten. I believe, Helen, I haven't had the pleasure of meeting you yet, but you're on the Board of Regents in Kansas. And she asks, if a person actually has the antibody, how long will it be active in the body to prevent reinfection of COVID-19?
So there are limited studies, but the studies that we have show antibody levels that are present for somewhere between 60 and 90 days, and then they seem to fall off, which would be a normal amnestic response. There are some preliminary studies that show that the so-called cellular response, which is the T-cell response, is much more enduring than that. And we're actually developing an assay with one of the large vaccine companies to actually quantify the cellular response. A lot of it is going to depend on how much genetic shift we see in the virus. We've already seen some significant genetic shift. So we're trying to figure out whether or not this is like flu and it's going to require an annual vaccination cycle, or whether it's going to be more like measles and mumps when it's once and you're done. Almost all of the vaccine constructs require 2 doses. There are only 2 of the warp speed products that do not. And by the way, 2 of the warp speed products, it looks like the Moderna and the Pfizer products, should be at emergency use utilization by the end of the calendar year. They are the 2 that are furthest ahead. Unfortunately, they're the 2 that are hardest to ship. They're the ones that require the deepest levels of refrigeration and the most complex handling. That would be the Pfizer product. But the numbers are just as recently, I was meeting with Asper folks on Monday of this week, are looking quite good.
Great. Thanks for that. It sounds to me like Representative Lyndon Carlson, a longtime legislator, longest serving legislator in the state of Minnesota, who's retiring this year, has a question with his virtual hand raised. But we're going to unmute you, Lynn, if you can unmute yourself if you still have a question.
I think I'm unmuted, am I not?
Yes, you are. Great. Go ahead.
Yeah. My question, when you showed the regions in Nebraska, a question that I've raised in Minnesota, in a general way, is our neighboring communities and the differing state policies. For example, along the Dakotas, we've got Grand Forks, East Grand Forks, We've got Fargo, Moorhead. The Twin Cities is very close to eastern or western Wisconsin. And if I narrow it down to just higher ed, for example, in the Fargo Moorhead area, you have the tri-colleges, and students are taking courses on all three campuses at times. So any thoughts about how to handle the differing state policies relative to the bordering communities, whether we're talking about employers having people cross state lines or customers shopping, or in the case of higher education, students moving back and forth across the state borders with differing policies?
Yeah, we face exactly the same thing, sir, here in Nebraska. We have a lot of different local public school districts, and different regions have, and even the local public health districts each have their own boards and each have their own sets of policies. Here in the Omaha Metro, the city council passed a mask ordinance. Lincoln Lancaster has one, several others do not. It's become highly politicized, as I'm sure you're well aware. But our approach is pretty simple. We know what works. We know what is going to reduce transmission. All we can do is share the science and hope people make responsible decisions. We've had this discussion. I mean, I speak with our governor and several others at those levels across the country on a daily basis. It's not about what you mandate, because it's almost impossible to enforce. It's about how people respond. If they're going to have watch parties in their basement and invite their 40 closest friends and enjoy every libation known to mankind, you can predict exactly what's going to happen. You may not predict who's going to win the next kickoff and pass return and punt return, but you can certainly predict what's going to happen from disease transmission, given the fact that at least 40% of the individuals who are infected are completely asymptomatic and have no idea that they're transmitting virus. So, all we can do, sir, is just provide local information and ask people to be careful. But what has changed now, as the rural farming and ranching communities, there's probably no community that doesn't have members that have been sick, hospitalized, or even tragically lost their lives to this disease. So it's become incredibly real, and that is to our advantage now. But unfortunately, I mean, I was just on a briefing call earlier this morning with our local public health districts. I mean, unless something dramatically changes, we've had just over 600 deaths here in the state of Nebraska. We are predicting in the next 8 weeks to go to 2,400 deaths. 4 times, just based on where we are sitting today. Well,
I was interested in your input because we've had those discussions. I happen to be on one of the oversight committees, and what we've done to date is basically try to use the education approach, if you will. But when you have differing state policies and large population centers on the borders, it becomes hard to monitor or to do the appropriate things that, at least as we perceive them in Minnesota, relative to some of our neighbors, which have been much more open. But I won't belabor it. I was just curious what your reaction would be, and it sounds like you have.
The non-pharmacologic interventions are solid science. That if you go back to my slides, there's nothing that's in the slide that's not based on science. But the enforcement of it is another whole issue, which touches on all the questions of food insecurity, home insecurity, stress, depression, and suicide, which are at all-time highs, street crime, all-time highs, in number of gun violence in the large cities in the United States, all-time highs. And so this is all a very, very delicate balance. And also just the progression of other diseases, the cancer that's not getting treated, the heart disease that's not getting treated. So I'm glad that I don't have to make some of these really very difficult decisions, but the science on what prevents the spread of the disease until we have safe and effective vaccines is crystal clear. That is not debatable.
That's great.
Thank you.
So we have about 4 minutes left, I think. And then before we close, I just want to make sure everybody knows we'll share all of this information and data with you after the Zoom call here. But Dr. Gould, do you have recommendations on sort of response and approach from a system level, and then from a campus level? So we have some very small private colleges or small, medium-sized publics, large R1s. Are there ways to guide kind of approach some things that are consistent across the board, but then that are tailored depending upon size?
Sure. I pretty simply, tight collaboration with your local public health department, because you don't want to cross swords with them. Secondly, a very, very clear and daily updated look at disease transmission rates and healthcare resource availability in your immediate area. That is to say, no matter how small or how large you are, if there are no more ICU beds, if you have nursing shortages that are draconian, if you're in what's known as surge capacity decision-making, which is now going on in several parts of the United States, which means that people are being turned away from hospitals, emergency rooms, et cetera, based upon tragically age and salvageability determinations. You need to know that and make decisions accordingly. Similarly, you need to just be very conscious of what is community acquired spread versus non-community acquired spread on your campuses. And I don't think it makes a difference whether you're a large R1 or a small, elite institution.
Thank you. We just have a couple of minutes left. And we need to end on time. I did want to ask you probably a non-controversial question.
Sure.
So this is, you bring up science, and I'm a fan of science, but we've seen across the country in our region, it doesn't matter. So Governor DeWine, who's a Republican out of Ohio, and Governor Whitmer, who's a Democrat out of Michigan, have both, they're not alone, but they've both been the subject of wide criticism for some of their approaches. Do you have suggestions or thoughts for some of our state or our state leaders with respect to how they might approach this, and how are there opportunities to depoliticize this?
Well, I think it's going to get somewhat depoliticized on Tuesday, or shortly after Tuesday. At least I hope shortly after Tuesday. I'd leave that to your own imagination. But I would say just communicate. I mean, I think that our university and college leaders are very important voices in your community. Try to use as much science-based decision-making as you possibly can. And, we have taken a position. I mean, we work very closely with the Department of Health and Human Services here in the state. We work very closely with the governor's office, but we make decisions on our campus by campus basis. That is to say, no one is telling us what to do. We are making our own campus decisions. And right, wrong, or indifferent, we try to base them on science. We communicate them. We try not to make them in a vacuum, but we do make the decisions as to what is the safest. And indeed, we've been very, we're seeing record enrollment on many of our campuses. And I will tell you, the most common questions that I get from students and staff and faculty, and frankly from family members of our students, is my student going to be safe? Is my child going to be safe? And can't write a guarantee, but every decision is based around that question. So is it political? It's highly political. But I would say if you communicate with those that are in elected office and those that are appointed to make these decisions, try to use as much science as possible. That's the road we've taken. Whether it will work for each of you, I do understand how complex and how delicately balanced some of that decision making is, particularly for our state-funded institutions such as ours. As a lot of our budget depends on our relationship with those that fund us. We can only hope that our support from all aspects of the public and private communities is based upon the quality of our decision making.
Great. Thanks, Dr. Gould. And with that, I think we're going to end right on time, which will make my folks happy. We will provide all of this information and links, et cetera, on our website, as well as the proper contact information. I want to thank Dr. Friesen and Dr. Gould. I want to thank all of you for joining us today. Please stay healthy. Thank you.
And wear your mask.
Wear your mask.